Today, this is the 16th module of the online PG classroom. As you all know, the main aim of this program is to make the PGs present a case and to discuss that topic in their exam point of view. Today, we have Dr. Rosemary Paul from Dr. Somerville CSI Medical College, Karakoram. And she will be mentored by Dr. Jasmine, Professor of Ophthalmology from the same college, and also Dr. Sheldon. And we have the external faculty, Dr. Hem from Dayal Eye Hospital, New Delhi. Welcome, ma'am. On behalf of the scientific committee, warm welcome to this program.
Thank you, sir. Thank you so much for that.
So I request all the PGs to participate in the discussion and make the discussions lively and active. So with these few words, I hand over the program to Dr. Jasmine. Over to you, Dr. Jasmine.
Thank you. Thank you so much, Baston, for giving us this opportunity. And I once again want to welcome all our faculty and all our PGs who have joined in this meeting. A special welcome to Sushila Madam. Madam has joined. And I know it's because favorite student, Haim, is the faculty today. So I'm so privileged to introduce Haim this evening. Haim was one of our most brilliant students, DNB student in our college when she was a PG here. And she's done us proud. She's done a fellowship in cornea refractive surgeries, and she's actively doing keratoplasties and refractive surgeries. So I'm so happy and so proud to welcome you, Haim, especially to preside on the other side of the table this evening. Okay, so thank you so much for accepting our invitation and being our external faculty. So with this, I'd like you to take over and let Rose start the presentation.
Thank you, ma'am. Thank you so much. Rose, please start the presentation.
Okay. Good evening, all. Today, I am presenting in case of a 65-year-old male farmer presented to our OPD with complaints of foreign body sensation, eye pain, and redness in right eye since 5 days. History of present illness. He was apparently normal 5 days ago, following which an injury to right eye with cow's tail occurred, after which he developed foreign body sensation, diffuse redness of right eye, and gradual onset pain, which was of pricking in nature. There was no history of any colored halos, floaters, and glare, no history of any discharge, no history of diplopia, no history of topical steroid medications. Past ocular history. No history of similar episodes in the past was present, and no relevant past ocular illness. Medical history. There was no non-comorbidities and was not on any immunosuppressive therapy. And family history, there was no relevant family history. In personal history, he was having a mixed diet, sleep and appetite was normal, bowel movements regular, blood habits normal, and no history of any alcoholism or smoking. Come to general physical examination. Patient was conscious, cooperative, oriented to time, place, and person, and the patient is examined in sitting position with consent. And his vitals was pulse rate was 74 beats per minute, regular and normal volume. Blood pressure 110 per 70 units of mercury in the right upper limb at sitting position. And respiratory rate 12 per minute, and temperature was febrile. No pallor, icterus, cyanosis, clubbing, left ventricle, or dependent edema was present. Systemic examination, cardiovascular system, S1, S2 was heard, no murmurs. Respiratory system, normal vascular breath sounds was heard bilaterally. Her abdomen was soft, non-tender, no organomegaly. Central nervous system, the higher mental functions was normal, and no neurological deficits was normal. Coming to ocular examination, visual acuity measured with Snellen's visual acuity chart at 6 meter distance. In right eye, the visual acuity was 6/24, improving to 6/12 with pinhole. In left eye, the uncorrected visual acuity was 6/24, improving to 6/9 with pinhole. His head posture was normal, no facial asymmetry. Visual axis was parallel. Extraocular movements, the adductions and versions was pulled in all directions in both eyes. Coming to the anterior segment examination, in right eye, the lid edema was present. Otherwise, the skin over the lid, slit margins, eyelashes, superficial height and width was normal. Right eye, the lacrimal apparatus puncture was well opposed, lacrimal sac normal, troplus test was negative, and in conjunctiva there was diffuse and circumcorneal congestion was present. In the cornea, there was an grayish white infiltrate measuring 2 mm vertically and 2 mm horizontally with an epithelial defect measuring 1.5 mm into 1.5 mm in the paracentral area, 3 mm away from the limbus, and the lesion was dry looking and had ill-defined feathery margins, and the depth of the infiltrate extended up to the endothelium and with Descemet's membrane folds and surrounding corneal edema was present.
So, Rosemary, sorry to interrupt you. Was the hypopyon present in this?
Hypopyon was not present in this case.
Okay.
In the anterior chamber, depth was Van Harris grade 4 and grade 2 cells was present. Iris was normal. Pupil was single circular 3 mm and lens grade 1 nucleus sclerosis was seen. Anterior vitreous was normal. Intraocular pressure was digitally normal. And in fundus examination, it was good red glow, media clear, disease normal. CD ratio was 0.4/1, A by V, 2/3, macula was normal, and foveal reflex was present in right eye. In left eye, the lid band and mixum was normal, and the lacrimal apparatus puncture was well opposed, lacrimal sac normal, troplus test negative, conjunctiva normal, cornea was clear, and anterior chamber, Van Harris grade 4 with normal depth, iris was normal, pupil single circular 3 mm, and lens, nucleus sclerosis grade 1 was present, anterior vitreous was normal, intraocular pressure was 15 mm of mercury with Goldman explanation tonometry, and fundus showed good red glow, media was clear, disc size, color and margins was normal, CD ratio was 0.4/1, A by 2/3, macula normal, and foveal reflex was present. Coming to the summary, the 65-year-old male with no non-comorbidities presented with the OPD with complaints of poor body sensation, redness, and eye pain in right eye for 5 days following an injury to the right eye with cow's tail 5 days ago. On examination, the right eye visual acuity was 6/24 with pinhole improving to 6/12 and 1.5 mm into 1.5 millimeters paracentral corneal epithelial defect with the surrounding grayish white infiltrate extending up to the endothelium was seen in the right eye. And the provisional diagnosis is right eye mycotic corneal ulcer, and both eye was having nucleus sclerosis grade 1. Come to the management. The patient was started on antibiotic eye drops moxifloxacin 2 hourly and eye drop natamycin 2 hourly in right eye. And to relieve the pain, supportive therapy with cyclopentolate 1 drop BD was started, and lubricant eye drops 6 times was started in the right eye.
Yeah. So, can somebody tell me what can be the differential diagnosis? You have given me the diagnosis. How did you prove it?
The differential diagnosis may be a bacterial corneal ulcer or a fungal corneal ulcer. We have to differentiate it by the clinical signs.
Yeah, but you need to prove it, right?
Yes, ma'am.
Yeah. So, how will you prove that?
By doing the investigations.
Like which investigations?
Corneal scraping.
Very good.
Find out.
Yes. Yes. So,
to find out the etiological cause.
Yeah, so in corneal scraping, generally we do gram stain, KOH, culture, and sensitivity. Then only you can label as mycotic corneal ulcer. Otherwise, we cannot. We are just giving a broad spectrum treatment, not a specific treatment. Because after we find out it is fungal corneal ulcer, we need to decrease the dosage of the antibiotics. Otherwise, the antifungals won't work. So as we are given too early, so if it is proved by all the investigation, it is fungal, then we need to decrease the antibiotic dosage to 3 or 4 times only. Otherwise, antifungals won't work on the ulcer. Okay. And what other what other causes can cause fungal corneal ulcer? Like you told, a cow tail injury, right? So what
Yes,
other
ma'am.
causes can give rise to fungal corneal ulcer?
History of trauma with vegetative matter.
Yes, very good.
Mm.
Then we have contact lens usage also. Generally, whenever there is an epithelial defect, we get a fungal corneal ulcer. Whenever there is a pre-existing epithelial defect, it is a route for the fungus to grow in. So other causes like contact lens use, impaired immune system, ocular surface diseases, topical steroid usage, as you mentioned in your history correctly, that patient was not on any topical steroids, right?
Yes.
And diabetes, uncontrolled diabetes. These are the other causes for fungal corneal ulcer. So can you tell me about something about the fungus? You know something about fungus, like what is common, what is uncommon?
The most common fungus causing fungal corneal ulcer is fusarium.
And which other funguses are there? Yeah, correct.
Aspergillus.
Yeah, very good. And
Candida species.
very good. Yes. So there are other PGs in the house? There are other PGs there?
Yes.
So what are the signs of healing? Signs of healing corneal ulcer?
Signs of healing. Patient-
Somebody else will answer me if they are hearing me. Somebody else can answer.
Yeah, Monica, you answer. Answer Dr. Haim's question.
The pain, redness, watering, photophobia, the symptoms will decrease
Very good.
on
Then
starting the treatment, and the size of the epithelial defect will decrease. The
yes,
infiltration will decrease. The satellite lesions, if present, will decrease. Decrease in hyperpine size, and
there will be blunting of infiltrate margins.
yes,
That's, yeah.
yes,
So
Rose,
Monica,
can you stop sharing, Rose, so that we can just see each other?
yeah.
Yeah. Him.
So how can you clinically differentiate bacterial from fungal? Can somebody answer?
Andrea?
Fungal corneal ulcer, firstly, they'll have feathery margins, and there can be satellite lesion. Whereas in bacterial, it will be more round, well defined.
Yes.
Hypopyon in fungal corneal is they're sterile. Whereas in bacteria, it is non-sterile. And bacterial, the hypopyon is mobile, whereas in fungal, it is non-mobile.
Good. And what about the symptoms in bacterial and
Symptoms
fungal?
are more in bacteria, while in fungus, the signs are more than the symptoms.
Good, good, very good. And in healing, one I think Monica has missed something. So we see vascularization also. Okay, in long-term cases, we see vascularization also.
Okay.
And what are the treatment modules? Can somebody answer? Somebody else?
Who will tell us? Anu?
Antifungal agents, cycloplegic drops, and anti-glaucoma medications to prevent secondary carcinoma.
Anti-glaucoma for every patient you will give?
No, only in cases where there are secondary carcinoma, trabecular.
So which anti-glaucoma you will prefer? Because sometimes some anti-glaucoma agents causes uveitis also.
Detroxylone.
Prostaglandins are not preferred.
Prostaglandins are avoided.
Yeah, correct. We don't give brimonidine also, okay? Because that also causes uveitis or inflammation in anterior chamber. So what broad spectrum antibiotics generally we give?
Moxifloxacin.
Antifungals, what we broad spectrum?
Natamycin.
Natamycin. What's the percentage?
5%.
Very good. And what were the other options before natamycin? What were the other
Amphotericin B.
antifungals? Sorry?
Amphotericin.
Very good. Yes. Voriconazole, do we prepare drops? Do we fortify it? Or we just give the drops?
45.
Nowadays, we have voriconazole drops also. So there is no need to fortify it. Okay. And when will you give systemic antifungals?
When the ulcer is not healing with topical antifungal. Scleritis.
Which antifungals do you give in our clinic? Which antifungals we are giving?
Amphotericin B.
Tablets. Which tablets we are giving?
Final years? Monica, Andrea? Rose?
Itraconazole.
Yeah. And
Oral voriconazole is not preferred because it has some dissonant actions, hallucinations.
okay, just read it, okay? So we give fluconazole also sometimes. Okay. And what are the adjuvant treatments for fungal corneal ulcer?
Cycloplegic.
Adjuvants means not the drugs. I'm talking about any surgical interventions which we do.
Therapeutic or aesthetic therapy.
Sorry?
Say, Andrea.
Say, Andrea.
Therapeutic penetrating keratoplasty.
When do we do a TPK?
When there is perforations of more than 2 mm in size, or else when there is progressive non-healing ulcer, in spite of giving an appropriate medical therapy.
When there is limbal involvement, then also we do TPK. And any other adjuvant therapies which we do for the better healing?
Intracameral, intrastromal
Very good.
antifungals can be.
Like antifungals, like intrastromal, intracameral antifungals, like what? You're correct.
Voriconazole.
Yes, very good. Yes, correct. So in adjuvant therapies, sometimes we do collagen cross-linking also. Okay, so that the collagen doesn't allow the fungus to go in. So we make the collagen more stronger by doing C3R treatment. Sometimes for fungal ulcer, we generally do a debulking process also. We do superficial keratectomy also, then anterior chamber wash, and temporary tarsorrhaphy when there is a non-healing persistent epithelial defect. So these are the adjuvant therapies for fungal corneal ulcer. Okay. Ma'am, anything you want to ask them?
Yeah, someone tell me what are the complications of a non-healing ulcer?
Rose, start with Rose.
Yes, ma'am. Descemetocele formation leading to perforation and keratoectasia, cataract formation, secondary glaucoma, endophthalmitis are the complications of non.
Anything else later on when the ectatic cornea and the iris get stuck together? Later on, can anything else happen?
Fistula formation.
Okay. Anything else? Anterior staphyloma.
Anterior
Sometimes
staphyloma also.
chronic cases, anterior staphyloma. How will we identify an impending perforation? Anyone?
Monica, yes.
There will be a descemetocele formation. High perforation. There will be thinning of the cornea and then formation of the descemetocele.
So what will we do at that stage when there is an impending perforation? Impending perforation means if we don't do something immediately, it will perforate. The cornea will perforate and then patient is likely to lose the eye.
Then we can use corneal glue to seal the.
What's the first thing that should come to our mind? There's an impending perforation, cornea is becoming thinner and thinner.
Intraocular pressure.
But yes, reduce the intraocular pressure. Okay, then. Have you heard of something called the Gunderson's flap?
Yes, we take a flap from the expansion chamber and then we take it over to the cornea and cover the defect.
Okay. Nowadays, people don't usually do that. But previously, they used to use the conjunctival flap. What was the benefit of that?
It will bring the vessels in contact with the defect and help in healing faster.
Yes. Okay. What is the role of, this is something I've discussed with you all in class also. Is there any role for patching the eye?
No, no.
Why not? Who will tell me? Rinsha. Rinsha, are you there?
Yes, ma'am.
Yeah.
Patching the eye can reduce the pain, then can aid in healing.
Really, is patching advised in a corneal ulcer? No, we're not talking about epithelial defect, but a corneal ulcer, a frank infection of the cornea.
No, ma'am.
Why not?
Because of the corneal, because of the reaction, and it promotes the microbial growth, and also it delays the healing.
Basically, it will
Then-
increase the environment. It will make the environment more conducive for the microorganisms to grow, as you said. Okay. So patching is not advised, but however, we can protect the eyes by asking the patient to wear
the
dark.
warm, moist, and
Correct. Yeah, they can practice lid hygiene, but they can use dark goggles for protection instead. Okay. How will you differentiate between a filamentous fungus infection versus an yeast infection? Just based on clinical signs, how will you differentiate?
Ma'am, for yeast infections, pearly white precipitate is seen in the eyes. And we have to differentiate it by using the laboratory investigations.
Whereas filamentous fungi have that typical feathery margins and all that.
Feathery margins.
Anything else? Connie?
What are satellite lesions?
Lesions is filamentous fungi.
How do you define a satellite lesion? And why do you get satellite lesions?
Meenu, would you like to try? Meenu, you're there?
Yes, ma'am.
Yeah. And sir was asking, what is a satellite lesion?
Satellite lesions are lesions which are found around the around the fungal corneal ulcer. Small lesions which are found around the.
How will you define a satellite lesion? Small lesions found around the main lesion. One more.
There has to be something in between.
With a clear zone in between the main lesion and the satellite lesion. Okay.
Is there any role of paracentesis in a impending perforation?
Yes.
How does a paracentesis help?
Paracentesis will help to reduce the intraocular pressure. Thus may promote healing better.
Okay. Now, suppose in your fungal corneal ulcer, usually a corneal scraping may not yield much because the fungus is deep within the layers. How else, what other microbiological investigation can we do then? Or what other specimen can we give to the microbiologist then? If our superficial scraping is not yielding anything. What other specimen?
Biopsy.
Yes. A corneal biopsy. So this corneal biopsy specimen, what are the tests that we will ask to be done?
Culture.
One is, of course, microbiology, culture sensitivity. Also, we can send it to the pathologist. They will also be able to identify the fungal filaments for us. Okay, so corneal biopsy is one more investigation we can. Ma'am, Sushila ma'am, would you like to ask any question, ma'am?
No questions. I just wanted to see all of you, especially him, because
Good
I've been
evening,
here
ma'am.
for a long time. And want to add one more thing. When Rosemary presented, she could have added the corneal sensation also. In all corneal lesions, it is better we present that the corneal sensation is present or absent or whatever it is. And one more thing, rather than using, this is my opinion, rather than using cyclopent, we can put homide, because when you suspect any inflammation, it is better to use homide or atropine or something like that rather than cyclopent drops. So these are some corrections which I think. Hemsha, you are there?
Yes, ma'am, definitely.
Oh, very nice seeing you. Seeing you
For a
helping
long
others
time.
also. And after a long time, I enjoyed the whole show. And the questions were very nice. The students are also very nice. Jasmine, they are
Yes,
also very good.
they
They are
are
also very good, Sheldon and
very good.
Jasmine.
They're all very good students.
Okay, okay. It went very well. Okay. Thank you all.
Thank you, ma'am. Thank
ma'am.
you so much. Hey, would you like to wrap up and summarize? And
Yeah, ma'am. Yes, so everybody performed very well. I am happy to see that these were my days before, and I was able to answer because of Jasmine ma'am and Sheldon sir, definitely.
you were a very good student. No, she was a very, very studious girl. And I still remember what the book that Habe used to read was Yanov. And I still tell my PGs, read Yanov, read Yanov. It's an excellent textbook.
So I think, ma'am, everybody is prepared for the exams. I think the third years mainly, they'll be coming with flying colors. I know that.
Over to you, ma'am.
Thank you, ma'am, for the invite. Thank you, sir. Thank you so much. It was very nice seeing you all here after many years. After many years. Thank you, ma'am.
Thank you. Thank you once again, Him. Thank you so much. Over to you, Pastor.
Thank you, Dr. Him, for that lead part in the discussions. And Susila ma'am, good evening.
Thank
And unlike other sessions, this time there was active participation on all the PGs. Usually, what happens like only the presenting PG will be like victimized, I'll say. Because questions will be bombarded to her only. But this time it was a different. So that Sheldon and Jasmine made that possible. So this is what actually we want for each session of the PG program. Not only the presenting PG is just presenting the case, but all the PGs should participate in the discussions. So thank you very much, Sheldon and Jasmine, for making this possible. And Dr. Him and Dr. Rosemary also, you presented it well. And I think it was a good show and a lot of learning points from the point of examination. And I still remember those days when Jasmine, me, and Sheldon used to present cases. In Manipal, it is like a
It's like terror days. The case presentation was a terror.
case to present is week job. In many weeks, you will lose your sleep. And once your case is over, then comes your next, what is that? Presentation, not presentation, seminar.
Seminar.
So again, you lose a lot of days of sleep. I don't know, is the same for the PGs now?
If you ask them now, they will say yes, yes.
It was like that. And good to see you all. And thank you very much and good night.
Good night.
Thank you, Bastin, sir.
you, Bastin.
Thank you.